So thank you for coming to the Gravity Project March 18th public call. We're going to be reviewing concepts in material hardship and stress. And then just kind of basically going through those concepts and not covering much policy and tech today, focusing on terminology. Next slide, please. I didn't introduce myself. So as many of you know, this is Sarah DeSilvi. I am the Director of Clinical Informatics for the Gravity Project. It's my honor to welcome you. We always mute folks upon entry because we usually have around 100 or so folks on the call. The call is always recorded. Recordings are available on the Gravity Confluence page following the call. We do, as you are aware, really strongly encourage participation in the chat. Please direct chat elements to everyone, and we will try to work them into the conversation. Next slide, please. This is a standard antitrust policy statement that we have to make. Next slide, please. For those of you who might be just joining us, we officially invite you to join the project by following the links. As I mentioned earlier, I don't know if I mentioned it, but everything that we discuss in the call today, we do try to drop the link in the chat for those individuals who want to capture it live. So if you've not already joined the project officially, you can do that at the first link. If you want to check whether you've already signed up or if others from your organization have signed up, you can review existing membership at the second link. And then for all other Gravity Project information, you can follow the last link, and that's for the Confluence. We do have some exciting in-progress work on a more gentle public-facing webpage, and we'll talk about that in a second. Next slide, please. Just again, a continual shout out and thanks to our project founders, our grantors, and our extensive in-kind support who helped make the Gravity Project go. Next slide, please. There's a lot of Sarah today. We'll go through announcements. We'll then talk about the project schedule and overview. We'll do some end-to-end review for material hardship, some identification of concepts for stress, and then we'll detail community homework and next steps. Next slide, please. So on to announcements. Next slide. We do mention the Gravity Project's looking always for additional sponsors for 2021 operations. If you're interested in learning more about sponsoring, you can send an email to the Gravity Project or visit the link at on the Confluence, which is the Gravity Project sponsor page on the Confluence. Next slide, please. The sister meeting that focuses specifically on tech for this meeting is the HL7 SDOH CC Fire ID public meeting that happens on Wednesdays from 3 to 4 Eastern Standard Time. It's available through the HL7 meeting calendar, and you can follow the link there. Next slide, please. We are very excited to say that the Gravity Project multi-domain ICD-10 submission was reviewed at the ICD-10 CM Coordination and Maintenance virtual meeting on March 10th. You can find materials from the meeting at the first link there. Just an incredible thank you to all of you who contributed to the development and review of the submission. It was incredibly well received, which was really quite exciting. We appreciate those who have sent in letters of support, and there's some further information about next steps. So going forward, we have two main comment efforts right now. So one is the general letter of support, including the rationale that's available on the Confluence, and it has been. This basically states why we feel like the codes are necessary at this time in general. There's citations, there's an explanation of each of the different terms. There's also an ask for a specific email to Donna Pickett, and there is a draft form letter for this as well. This is to specifically request that the codes be released as part of this year's October release, and to not be postponed until 2022. We have been working with the committee for some time. There might be some bandwidth for assisting them to build these concepts in for the October 2021 release. We do need to make that case. So both of these letters are available on the Confluence site on the ICD-10 page. So both, again, the original general letter of support, if you just want to send a letter of support, and a specific text for an email that one could send to Donna Pickett, and the information of how to send that email is on the Confluence site as well. Any questions regarding this before we move on? All right. Again, it was very exciting. We're very grateful for everyone who helped. Next slide, please. We also are excited to announce that we've been working with Spire and off of the incredible efforts of Highmark, who helped us earlier this summer, to create a kind of public-facing website to better introduce the project. The website has a soft go live right now. You can go and see the landing page, which has overview descriptions of kind of the general context of the Gravity project. Right now, all of the cascades cascade back to the Confluence, but we are building the cascading pages as we go. We really look forward to getting your feedback as Gravity colleagues and Gravity members about how the Gravity project website feels to you. You can send any insight to gravityproject@emiadvisors.net. We're very, very grateful and excited to all the folks who helped get this out there into the world. As you know, the Confluence can be a little overwhelming. So it seemed like a necessary thing to make this more digestible site. Next slide, please. I wanted my policy kin on here, so either Evelyn or Mark to describe this next policy initiative.
Sure, it's Evelyn. Can you hear me?
Yes, we can.
Okay, so yes, so actually this is not policy, it's grant. So this is a grant opportunity for all our Gravity community. If you have not already heard, ONC has published a grant opportunity under their Leading Edge Acceleration Projects, or LEAP, where they are they're seeking applications. They did have a information session last week, and the timeline is submissions are due May 10th, but the letter of intent to actually apply for the grant, it's $1 million over 2 years to support standardized social referrals. So it's really around the ability to capture and exchange SDOH data in support of social referrals. So the information's on the page here. Anyone, again, it's open for those that are working in this space and are seeking to advance the use of standards. The grant actually incorporates the Gravity terminology standards as developed through this committee. And Lucy's asking, are we applying for the grant? We will be putting together, so on our end, because it does call out the Gravity standards, and we have much interest from a lot of our partners, we have decided to just put together a one-pager on what we would offer as being part of a partnership. So we know there's a lot of interest in this. We have not made a decision of who to partner with, but we will submit a letter of intent that we are looking for partners. And again, this is really about testing and advancing SDOH standards. It does include the Gravity Project SDOH Fire IG, as well as other standards that are applicable to exchanging referral data and long-term services and supports data. Any questions? Thank you. Thanks, Sarah.
All right. Next slide, please. I can lead on this, Evelyn, unless you wish to. Evelyn, do you want to take it?
Sure. Just this is an announcement for those who are not yet aware. ONC is hosting their annual meeting at the end of the month. There will be several topics of interest. It's free to join. It will be virtual. We're letting our community know that both Bob Dieterle and I will be presenting. I will be providing a quick gravity overview, and Bob will be focused on consent, the work he's doing with the Fire IG build around consent. So please join us if you have not already registered for the event and are available. Thank you.
And that was perfectly timed to avoid my dog barking. Thank you. Next slide, please. All right, so on to the project schedule and overview. Next slide. You can see we do try to keep things updated. So right in the middle of wrapping up material hardship, which we're covering from screening and diagnoses and goals and intervention. We kicked off stress last meeting. We're heading into looking ahead to social isolation next, and then intimate partner violence and elder abuse combined together, kicking off in mid-April. The aim is to get the comprehensive data set for material hardship and the screening questions and answers and diagnoses sets for stress, social isolation, intimate partner violence, and elder abuse complete by the middle of June. We then are taking a break. This is a community break. There will be a lot of writing from the Gravity work, the Gravity team in collaboration with our terminology standards over that time. So even though it's a break for the community, we'll likely just still be laboring a bit. And then in August and the fall, you'll see us kick off some of the neighborhood domains we've talked about in the past. Alongside all this work is the technical work that my colleague Bob Dieterle runs. So you can see that we're heading into, we're doing the ballot reconciliation. He's actively doing that with his team. And then down at the bottom, we are working on the Gravity Pilots recruitment. So these are basically the 3 streams of the Gravity Project, all intersecting all the time. And then Lucy, please put Gravity time and ONC annual here. I don't know what that means. Can you, what does that mean?
I think she's asking for our meeting time. I believe it's a 2:30 or 2:40. Yeah.
Okay, there we go. Okay, that's okay. We can do that. Okay, thank you. All right, next slide, please. This is just an overview of the integration of the 2 streams. Next slide, please. And then this is the overview of the use cases. We include these each time just as a reference, but I'm not going to touch on them very much. We have some new things to discover and discuss next. Next slide, please. You can see here the new icons that match the icons that we see on the website. Again, the goal of the Gravity Project is to develop consensus-driven data standards to support use and exchange of social determinants of health data within the healthcare sector and between the healthcare sector and other sectors. Next slide, please. I wanted to take a little bit of time to ground individuals just on some context of all the things that happen behind the scenes that are not in the meetings. So we had a really robust meeting last time, but I feel like there were some questions asked by the community that I would love to answer. So we're just going to take a couple slides to just talk about basically the history of the project very briefly and the role of subject matter experts and how we glean information from the community and then build it into our adjudicated data sets. So really the intent of our public calls is to present updates of Gravity materials and offer opportunities for the community to reflect and discuss implications. The community has a critical role in ensuring content's representative of needs. We welcome ideas for additional or altered content to be submitted via the Gravity process, and that's available here. The reason why we're stressing this is as we've evolved as a community, there's often lots of suggestions for new data concepts, but they're not submitted via the formal process. And so it makes it very difficult for us to run them through our subject matter experts who we ground all of our work on. So for each domain, we have critical subject matter experts that we've contracted with either through in-kind support or actually contracting with them in order to assist us in this work. And we always leverage our federal resources as well. So we're asking that any additional terminology requests that we go back to the process of having things be submitted. The submission process is detailed on the Confluence. When you're submitting concepts as part of any process, we need to offer rationales with evidence for suggested alternate approaches. Otherwise, it makes it hard for us to make the case to the subject matter experts about why those new concepts are needed. Essentially, as an evidence-based project, all elements must be assessed by our subject matter experts prior to inclusion in the set. So we're hoping just to kind of return to that formal process for when we have ideas for missing data concepts so that we can formally review them, track them, and then formally respond, just so that we're not losing things in the process. Does this make sense?
Sarah?
Yeah, hello.
Hi. Is there any tension between using this wonderfully large group of incredibly diverse experience to suggest what's important versus what is already documented and therefore can be said to be evidence-based? It seems to me that one of the virtues of a process like this is to potentially discover aspects of social determinants which haven't been studied yet, but which should come to attention. And that this Gravity project seems an appropriate platform for doing that. I would also comment that the notion of evidence-based necessarily involves everyone being on the same page about what constitutes evidence. In other words, what kinds of studies of what quality. And we all know from reading meta-analyses that huge numbers of studies that come up when you type in some phrases turn out not to be high quality studies. So could you elaborate on how you address evidence-based in conversations for Gravity Project purposes? And then what about new ideas that come up that haven't made it into the literature yet?
So I think so that's like three questions in one. I'm going to try to do my best to get them in turn. So the first concept, and I think in future slides you'll see this. So this is specifically regarding this slide regarding ideas for terminology suggestions, program suggestions, diagnoses suggestions, screening tools on the domain at hand. So when it comes to this slide, we're talking about the best process to submit ideas for what needs to be said. So there's no vetting prior to that idea making. It's not, there's no limit to what can be suggested. It just needs to be suggested in a way that we can track and analyze and have conversations about. There's lots of conversations that happen behind the scenes with individuals who've submitted concepts in direct conversation with the subject matter experts via email, via phone call, via Zoom. So that's happening continually. So not all of the conversation we're having regarding the concepts happens here, but it all is possible. So if anything anyone has regarding an idea about what needs to be said regarding a given concept, it can happen. It's not like we pre-screen everything or anything really. And then when it comes to literature, we of course are very aware of the youth of the literature in this space. We ground ourselves specifically in literature across a couple different areas. So one is the literature of what's already been designated to be focused on, and we'll see that in some of the Academy reports coming up. And then there's two different kinds of health risk literature that really comes up. And so one is the literature of measurement of the domain at hand. So when it comes to looking at the domains, whether it be food insecurity or housing instability or homelessness, we really lean heavy upon the literature of measurement. Like, how are individuals in the ecosystem defining these concepts? Because if you've been with us for a while, and Lucy, you certainly have, often we're defining things that haven't been defined before. So again, it's not like there was a roadmap. Like, we really have to work with our community to put things into healthcare terminology that haven't been defined yet. And then beyond the literature of measurement, we also look very heavily to the literature of health risk. So across our subject matter experts, we pull experts of measurement and experts of health risk associations, principally because we're building health terminology, and that's where we ground our work, but all the while recognizing the youth of that literature just to keep us honest. Is that a good answer?
Terrific. I hope that's written down somewhere.
Well, luckily it's recorded.
Will
Lucy,
be now, right?
I thank you for asking really good questions. And this is part of why we wanted to do this today. So again, just to remind individuals, the hope is for terminology submissions that we submit them via the process that we have stated on the Confluence, because honestly, I just want to make sure that we capture these ideas. And it can be challenging if they're just placed on the in the chat. And we have a process for this, and then we can actually work with you directly via email, via phone call, in order to make sure your ideas are represented. Next slide, please. And this is just a kind of a reminder about domains. So one of the things that was happening or can happen is that we can have questions about domains we've covered in previous builds in the presentation of the domain at hand. It can become a little bit difficult to answer questions about past domains when we're working on present concepts. And so we really want to take some of those conversations offline in a formal way. So when an individual is raising a question regarding a domain that we've addressed in previous sets that's been voted on and resolved, what we'll do is work directly in the chat to get that individual's contact information, to talk to them offline, to really try to make sure that we reach out and help them understand all of the materials that we've done so far. And that way we'll all be on the same page when it comes to addressing concerns, so that we're not leaving anyone behind. Does that make sense? We're even going to post links to the domain at hand on the Confluence if that domain gets raised. Does that make sense? Sounds like it does. So another thing that we wanted to mention is that we gather all of our subject matter experts by domain. So one thing that can become challenging is we can touch upon concepts that cross domains we've yet to cover. And so one of the things that we explore, and we say this very gently, is we explore pausing, building on concepts that we don't have the team assembled to address yet, just because we are really focused on trying to do these concepts well. So whenever that happens, we have a specific thing that we're going to do, which is placing that domain basically in onto our into an assessment of how it corresponds with the things we're already contracted to address. And so we'll hold that domain. But what we wanted to really clarify, and you'll see this actually in the material hardship concepts as they come up, as not only terminology experts, but taxonomy experts, the one thing that we plan on doing always is making sure that whatever choices we're making in our terminology and taxonomy allow for expansion of that concept in time, right? We will not box ourselves in. So the example that I think about here is literacy as a driver of material hardship. We talked extensively about this in the last call. Material hardship right now, the concepts that we have the team to address is specifically regarding the absence of financial resources. And so we found ourselves not having the resources and the team we needed to address this. And we've talked about literacy across multiple different meetings about really needing its own domain and addressing that in the fall. So when we cross and hit these moments where we feel like our subject, the best way to address that is with the domain experts to come, we're just basically going to ask the community if it's okay to acknowledge the timeline, pause, make space for it to come back, and then return in time. Does that make sense?
Yes.
All right. Okay. Next slide, please.
Majority of one here.
Yeah, I know. I got a couple of thumbs up. Right.
Good.
There were lots of questions on the last call as well about how domains got picked. And I did not have a good answer then. I said something about because they're in the ecosystem, right? Which really isn't sufficient. Because the truth is the anchor of our domain project plan really rests in the foundational NASEM reports capturing social and behavioral domains and electronic health records, both phase 1 and phase 2. The reason being is this was basically the charter of national experts across the country determining what are the critical social risk and psychological domains that are necessary for building into electronic health records at this time. They graded domains phase 1 and they graded domains level 1 and domains level 2 across 2 really robust and wonderful reports. You can see many amazing mentors and colleagues and inspirational folk on that committee. So the phase 1, each of these papers are linked in this document, and then we'll make sure that they're available on the Confluence as well. They're part of our references, as I think, as it stands. But the phase 1 charter, and this was in 2014, was to identify specific domains to be considered by the Office of the National Coordinator and to develop criteria that should be used in deciding which domains should be included. And then identifying core social and behavioral domains to be included in all health records, and et cetera, et cetera. And then the last thing I think is crucial when we think of our third use case and identify any domains that should be included for specific populations or settings defined by age, socioeconomic status, race, ethnicity, disease, or other characteristics. So when we think about our initial charter, you'll see that many of these domains are part of that recommendation. So Ruth, that's a good question. So if we go to the next slide here, you can see what the core domains were. So the selected domains that are represented in the phase 2 report, phase 1 and phase 2 report are as follows. So we have socio-demographic domains, including sexual orientation, race and ethnicity, country of origin, education, employment. Financial resource strain really encompasses so many different things. So it looks like it's just 2, but underneath that concept, we're pretty much all economic drivers of social risk, which is why you can see it kind of expanded on our timeline. Then it has psychological domains, including health literacy, stress, negative mood and affect, depression, anxiety, psychological assets. Then there are behavioral domains, including dietary patterns, physical activity, tobacco use and exposure, and alcohol use. And then individual level social relationships and living conditions, such as social connection, social isolation, and exposure to violence. You can see many of these domains are on our project plan, and that was intentional. It was by design, responding to this paper and ensuring that as really Gravity has been given the charter to address the terminology and data standards needed to meet these goals. So this is really a core of our focus. The question of whether or not we will address other psychological domains, we really leave that to our committee structure and the community. So what we're working on right now is ensuring the socio-demographic and social relationship and neighborhood domains that we've already charted to do are on our timeline. And then we certainly, because this is Gravity's charter, will loop back as the community, our strategic advisory committee, and the executive committee just tell us where to go. Yeah, so if you can see, Tom, next slide, please. So you can see, for the sake of the community, I did parse out the whole the candidate set and reviewed but not selected set, because there's a lot of things that we know are really critical, which were in reviewed but not selected, that we've already elevated. So Tom, I'm going to agree. Gender identity is right there. And then we also have a host of influences in the neighborhood and communities section that we've already designated to be critical, especially to meet our population health use case. So I'm going to agree that we're not bound to do everything just in the selected set, but it's important to consider that this is kind of where we drive and derive our focus from. All right. Mike, this is actually literally responding to your question. So I hope one of the things we realized is we needed to make explicit to the community some of the anchors of our approaches and what we've been working from the whole time that we really maybe hadn't made clear enough. So this slide deck really tries to address that, to really help the community understand what the anchor of our orientation is. All right, any questions here?
Sarah, this is Evelyn. I just want to let the community know that, per the emails you were privy today, there's a lot of work within HL7, in particular the public health and I think the vocabulary work groups around sexual orientation and gender identity. They actually have a project called SOGI right now, and we are just trying to tie in with them, but acknowledging that there is ongoing work right now under HL7 to define the standards and the vocabulary for sexual orientation and gender identity.
Evelyn, thank you for that, because USCDI does not acknowledge any of this.
Yes, and they have been working on informing that. So it's an ongoing project, and of course it has relevance to gravity. So just today, there's a flurry of emails on it.
And to add on to that, Evelyn, SNOMED International has undertaken a project, Sex and Gender Clinical Project Group, that's currently reviewing the sex and gender identity content in SNOMED International.
Excellent. Okay, yes, I think they're very much involved with SNOMED, and I know IHE too, international has been
Also,
involved.
the last HL7 ballot had an informational ballot about gender harmony.
Okay.
And the ballot passed. And last I heard, they were working on like the comments that had been made.
Yes, it was just balloted. I think one of our committee members sent us an email today. So they have been looking at it also to inform what's in USCDI. So it says, I'm just looking at
And
my.
I think they're looking to address some of the gender harmony issues in R5, which they're expecting Q2 of 2022.
Okay, great. Thank you. Yeah, and again, for us, and I don't know if Bob is on, but really we want to, our whole purpose with our project, and so appreciative as Sarah going through this, we know there are other activities. As she documents, we look at the evidence, right? So we figure out what already exists. And then, we build on it. And the same applies for the standards work. So before we go and develop new data concepts, we look to see what's already been developed by the standard development organizations. And we appreciate there's a lot of work in this area, and we'll make sure to connect with it.
And this list was, sorry, this list was generated from HL7 work group.
Oh, which list? Do you mean the list on the screen, or?
Yeah, I can't read the top because it's covered up by viewing Linda Hyde's screen for some reason.
Okay, no, so this is from the, if we go back a slide, or two actually. Sorry to be a pest. I'm going to take her because the links, actually, I think the links are in the chat too. So Julia, the domains that you see on the slide, folks might need to mute just because of that feedback. The domains you saw on the next two slides are all the Academy's reports capturing social and behavioral domains and electronic health records. Oh, I think there's still feedback. And the charter there was to select the critical social and psychological domains to build into HIT and EHRs. And
so that's the unadulterated list. It's not from any of the other projects that we just talked about. It's just the original one.
Yes, so that is literally a screenshot from the report. Yes, ma'am. So if you go next slide, this is a screenshot from the phase 2 report. And then next slide, this is a screenshot, I believe, from the phase 1 report. So you can see they're weighing, right? So all the domains that they considered for the inclusion, and then the domains reviewed but not selected. And then each in the chapter 3, what they do is in this report is go down, like, just similar to how like Gravity does in its, justifications from rationales, each of the different domains and why it was escalated and elevated. and we only, this is, I mean, again, there are things that we feel like are not on here. And again, we definitely feel like this isn't necessary. There's things on the right side of the list that I feel like should definitely be on the left. But again, from an evidentiary perspective, we try to reference this. But we have a process to discuss whether things that are not on here should be on the timeline, and that's the public collaborative and the strategic advisory committee and the executive committee. So we leverage our group and the committees to determine what's next that's not on the agenda yet. It is a lovely, I'm not a, I mean, this is it's a lovely set of reports. So I'm going to try to, Julie, did that answer your question?
Oh, yes.
Lovely. Okay, so then Matt's asking, is gravity impacting the definitions of the NUCC taxonomy, which defines healthcare and human services provider semantics? We actually have looked at NUCC, or talking about it when it comes to some of the building this syntax of our roles and programs into HIT. So it's in the ecosystem of some of the things we're considering when we consider how to build, again, our novel roles, which are critical for addressing social concerns, and our novel programs. There's a nice little Go John and SNOMED. Indeed, Go John and SNOMED. And then I don't know if I understand this. Would it be useful to add other, for example, in each domain to capture those listed as not selected? Do you mean in our presentations to the community? If you can type, oh, I guess if you can clarify that, that'd be, we're happy to, you can see that this presentation is really in response to a community request. We're always happy to respond to community needs about how to do a better job. Okay, and then I think we are good. There's like some sweet little commentary in there. All right, so next slide. I think that this is the end. Any questions regarding, this is really like an orientation overview and kind of a community practices refresher, just to make sure that we can have good conversations and that we follow our process, which really is a process just to enable us to really honor and consider and weigh every suggestion the community has. All right, next slide, please. Oh, on to terminology. It's the Sarah show. There's lots of Sarah talking. Next slide. All right, so here we go, folks. We are on March 18th. We are doing material hardship screening, diagnoses, and goals end-to-end review. I threw a little bit of programs in there just as a teaser. We're talking about stress screening and diagnoses concepts. Next meeting, we'll be kicking off social isolation, anchored by the expertise of the stress measurement of our colleagues at the Coalition to End Social Isolation. We just have had such a set of amazing, robust conversations from that TEP already. They're a technical advisory panel, this national coalition of national experts, and they're leaning in to assist. We're going to be then going through material hardship review and identifying more stress concepts. We are trying to set a timeline. You can see these bubbles on the side for when, if the community has submissions for concepts that they would like to be part of the data set to submit by. So hoping to get our stress concept submitted by the community by the process that's on the Confluence by April 1st. Hoping, because again, we need to digest them, review them, process them, meet with the subject matter experts, weigh them. Hoping to have social isolation concepts by April 15th, and then hoping to have intimate partner violence and elder abuse concepts by April 29th. Again, flexible, but really trying to create really clear, at least communication from our side regarding what the hope is, so we can do the coordination with subject matter experts in the community that's required. Any questions on this? All right. Again, this will be then translated into the agenda that you see on the Confluence, so it's available for reference at any time. Next slide, please. Next slide. So focusing specifically on material hardship, you can see I'm letting go of financial insecurity because I felt like some of those slides were a little confusing to folks. So really focusing again on material hardship, which is the lack of specific socially perceived basic physical necessities. This is the meta concept. It encapsulates all of material hardship. And as we've talked in the past, there are many different reasons why an individual might not be able to acquire basic physical necessities. It's prompted a lot of our conversations in the past. Next slide, please. We have our tools that we've talked about in the past as well, tools such as Prepare or Health Leads or WellRx. There's lots of really wonderful questions as well in the Children's Health Watch screening assessment that we leveraged for part of our food insecurity build and our housing instability build in the past. Next slide, please. You can see here, we have narrowed this down considerably. There's a couple things that are different from our last call. So number one, responding to community requests for specific concepts for each of the different types of lack, whether it be childcare, phone, internet, heat. So unpacking utilities, basically. We did that. And then because of the complexity of representing undifferentiated material hardship, right? The material hardship that's not related to, it's not in the ecosystem, right? It's not available, which we've already committed to addressing in the fall, right? Or the complexity of addressing things like literacy, right? We're specifically leveraging the intent of the questions, such as in Prepare or in the WellRx or in Children's Health Watch, which are, I don't have this thing because I cannot afford it. I do not have it because I cannot pay for it. This actually really clarifies our approach. It clarifies the concepts and terminology that are necessary. I hope that you see that there's room for expansion, right? I do want to state that if we add concepts of literacy, they might not be here. They might be in an education tree and a taxonomy far, far away, right? Once we figure out where those codes need to go. But we try not to box ourselves in. So this is the approach we're taking going forward. You can see it maintains the term hardship. That is the core of the experience. So if one was searching for terms, you would be able to find it this way. And yes, John, this slide was made prior to our lovely conversation today. So this SMEs would be willing to change secondary to due to better align with SNOMED. Yes. Or Carrie, I mean, I think I don't think you care about secondary to. I think due to is sufficient. I hope so, at least. But yes, John, that is entirely feasible. Any thoughts here? Does this seem like a clear path forward? It seems so. Does it seem, yeah. So we do have financial insecurity as a concept already, right? So the general experience of being financially insecure is represented in a different area. So if you're just having a difficulty paying for many things, the clear ask from our subject matter experts, and the clear ask, as we can see in some of the literature regarding health risks, and the clear pathway that we've seen in many of our screening questions and answers, which don't just ask about whether you're having a hard time affording it. It's like literally like, do you have heat? Do you have electricity? Was that we had to define the absence of the thing itself. So Tom's asking if there's a difference between financial insecurity and financial hardship. If not, should we settle on a single phrase? So that's an idea we can take back to the community, certainly. It looks a little bit like a post-coordinated term. It is difficult to establish causality without starting to look a little bit well, pre-coordinated or post-coordinated. I'm trying to, Mike, do you want to unplug yourself so you can help me? So we we got a clear ask from the community to define causality here because of all the different possible interventions based on the causes. So about 6 weeks ago, we presented material hardship without any causes, right? None, right? And there was a clear push from the community to clarify cause, because what I do when someone does not have internet because they lack broadband is very different than what I do if someone does not have internet because they can't afford it. And so this was a very clear response to the community saying, this is important because when it comes to defining concepts and associating them with interventions, this is necessary.
Yeah, well, I just unmuted myself. Sarah, I agree with that approach. I think I'm just thinking about in the field when we have to assign 6 diagnoses to a single root cause. And that's hard. I'm just trying to think of the burden that we will have for people to be consistent in recording things at the layer of granularity that we want to have them record things at. That's all. And I understand the trade-offs here, and I think you guys are making good trade-offs. It's just I keep putting this in the filter of somebody in the field trying to use this in everyday work.
I hear you, and I think that this is part of what we represent as this is a hypothesis, right? And I cannot stress how hopeful and how grateful I am for many of the folks who are already out there implementing these as like test concepts, right? So I think implementation will teach us a lot about whether this is as necessary as we presume it to be based on gravity feedback, right? Or whether we need to alter our approach. I hear you, and because I'm 3/4 time family practice,
Yeah.
so
Yeah.
I hear that. Yeah.
And just maybe a last comment here before I shut up is trying to think of how this would go in the field, and without the secondary twos, you could see this working, or with financial hardship leading to a specific intervention based upon the secondary two part. But I think sticking with this at this point, just seeing how it works in the field is probably the best compromise I could think of right now. So don't want to detract from the work that's been done. I'm just trying to think how this works.
No, I think, and Mike, I want to honor the fact that when it comes to people who are implementing and able to give anticipatory guidance on this, and they look at me just leveraging a clinical term. You certainly are one. So very, very grateful for your insight, because you really are doing work far, far downstream. So thank you so much. There's a question regarding whether having a device to access the internet, PC, phone, being included under unable to obtain internet secondary financial hardship, or is that somewhere else? We actually haven't built the device concept specifically, like unable to afford computer or phone. So if you wish to, like phone specifically, so if you wish to submit, again, we're hoping that if we feel like those things are important, we submit them, and then we process them together collectively, formally, to see if they rise to the top. Certainly, I can imagine in a clinical setting applying phone connection to the instance where someone did not have a phone also, right? I can imagine it being a parent concept, or I can imagine a use case where there would be a need to define the absence of the phone itself. John's asking, will you be able to clarify financial hardship? Is it a simple inadequate income or decreased income or broader scope? We will certainly include definitions. The idea was initially what we had was limited financial resources, which is again a concept we hadn't used prior. It may be that we need to go back and forth to clarify a little bit better what we mean there. This attempt again was to try to integrate the language we've used regarding material hardship into these concepts, but maybe it's not, maybe it needs a little bit more refinement. So John, if you have ideas, of course you do, or if any of our other individuals have ideas, please submit them to us. There appears to be potential opportunity cost or loss if someone has to choose between the various needs. Yeah, so I think what we want to enable is, I hope that if we look at the comprehensive scope of what Gravity has created, I can simply code that my patient has financial insecurity, right, based on what we determined before, right? And that's important because that concept transcends income, right? So by Gravity's previous work stating that I have a difficult time paying for things, if I don't want to drill down into these elements, I do not have to. But what we, again, and we should have included this, I always reference again the Gottlieb and Alderwick lexicon of social risk concepts, right? So the idea between social determinants, social risks, and social needs. The idea is supposed to be patient responsive. So ideally, the patient's like, I just am like, I have no heat in my house. Like, I can't afford the electricity, so we have no heat in our apartment. And then you can connect with specific resources. So it is a fair bit of one can imagine one's making choices, but hopefully those choices are driven by the patient, right? And again, this will all come out in the wash. We have to implement these things and see how we do. I hope that's a good enough answer. So Asha is really swept in to be helpful and drop in the data element submission process just for reference. So I hear we have some concepts regarding defining hardship. Thanks, Asha. Yes, indeed. So for SNOMED, and I think I'll put that in the cogitator and see what comes out, but if anyone has any other ideas. We tend to find ourselves using terms, we're going to have to define whatever we create here. So this was a first stab. And again, this is to create consistency across literally what one literally might be searching for, right? So as a clinician, understanding how I find terms, we were working with our subject matter experts who are also clinicians. And this was the thought that maybe this might be an elegant weaving there.
So Sarah, have you agreed to say due to instead of secondary to?
I believe we have, because the kind John Snyder has asked us to,
Okay.
and that is where we are building these things.
Thank you.
Could we use a combination code submissions to link financial hardships or material hardship to the determinant? So Matt, as a clinician, I'm trying to understand, an ICD-10 user, like, so can you unplug and help us understand what the benefit of what you're describing and what you see playing out?
Yeah, I'm trying to address this concern that Mike raised of essentially every determinant, say childcare, phone, internet, heat, kind of being duplicated across these two different reasons: financial hardship or material hardship, right? And so that essentially doubles the number of potential codes, which makes it difficult for the clinicians. So if you were able to use a combination, again, I'm not an expert on a combination code, so I'm not sure if this would be appropriate. I was just kind of like Googling around. But if you were able to kind of link, the determinant itself, say childcare, with as a very simple code that could then be attached to through a combination code of financial hardship, or then that might simplify things, or maybe it would just complicate things for.
Sarah knows that I'm going to jump in on this. So
Please.
I bring this up all the time, right? What you're calling is called post-coordination, right? Instead of saying one concept that contains both ideas, you use two concepts, and in combination, those two concepts mean a condition containing both. For example, I frequently will code post-COVID syndrome, and then put a second code in that describes what the manifestation of that is. So let's say the patient has POTS. So I code palpitations and chest pain and post-COVID syndrome. And that turns out maybe to be POTS. I don't know. But for this, I think it's important to not, because now let's say I'm the clinician and I see that both codes exist, which is something that's not likely because it's incredibly hard for me to find the code that I want in the first place. But that being said, how do I differentiate the financial hardship childcare flavor from the material hardship childcare secondary to financial hardship? I agree that it can be confusing, and what we'll get is splintering of the use of the codes, and some people will be describing the same patient using different sets of codes. Now, I'm not saying that doesn't happen all the time anyway, and that we're not going to solve that problem here. But again, I think it's very useful for us to consider if we can identify a set of reasons associated for material hardship and use financial hardship with the specific material hardship concept. I know you'll have an answer for me, Sarah.
Can you repeat that again? I mean, just the last part. You want to?
So that we would make financial hardship the reason, the linked code to the material hardship, but that we wouldn't ask for a separate code describing it. Because I think what we have as a concept is, lack of childcare, and then the reason is secondary to the primary problem. And then financial hardship as a concept becomes, related in a more structured way without needing another set of codes.
So we would then return to financial insecurity because that's a concept we've already defined, right?
Yeah, sorry if I misquoted that.
Yeah, no, that's fine. But this is literally the opposite of what was asked of us 6 weeks ago. So if that's the desire, we do need to just acknowledge that the losses of that. So there are, I would say there's an equal number of folks asking for this pre-coordination as there are folks asking for the post-coordination. So it's tricky to figure out how to go forward, honestly.
So,
And I
John,
don't have the answer. Oh, hi, John. Yes.
Can I add in to Julia's
Please.
point? So with the first description that you gave with selecting one code and then two codes, when you transmit that downstream, you have this code and you have that code, but you cannot state a causal relationship between those two codes. With having a due-to relationship in a pre-coordinated concept, now you have a concept where you're stating causality, and that's very different from what you're describing at the beginning. If that makes sense.
That does make sense.
Well, and I'll say there's what does Rapoport say? There's lumpers and there's splitters.
Yeah.
Like there are people who prefer the pre-coordination, people who prefer the post-coordination. As a user, I don't prefer pre-coordination. It's much easier for me I think about concepts in my brain in a post-coordinated way. It's much easier for me to select the drop-down because maybe I don't know what the cause is, right? So it allows me to have a different level of optionality and not to assert, as John just said, causality where it's not my call or I can't say one or the other. It also would allow me to assert multiple causes without having to select, multiple concepts here. Like it really clogs up the problem list when we create too many individual flavors of something. And, you end up seeing like a patient with diabetes that has 6 different ICD codes because one person said it was ICD with insulin dependence, and one person said it was the most generic code they could find, and one person said there was renal involvement, and one person said there was not renal involvement, and they're all on the list. And basically it's like, now there are 4 things and they're all the same case of diabetes.
The one thing though is that post-coordination depends on platforms, right? So part of what we, again, we can build both, right? We can allow for both truths, right? As long as we understand that I we do not have the bandwidth to build the other causalities at this time. We don't have the team on hand, right? The way, and yes, I mean, the problem with, oh my gosh, diabetes, sharing diabetes with an ophthalmologist and a nephrologist with current ICD specifications is a thing. It's a whole thing.
Yeah.
Right. So, because your CKD that you want to specify to is my hyperglycemia and is his retinopathy. I get it. Right. I get it. Like, that's a problem. But that's also, so is there a way, I guess what we can do is imagine, I suppose we need to figure out a way to rectify this, because we again have folks who are asking for this to be pre-coordinated and folks who are asking it to be because they want the causality, right? They desire that, and they're not actually very loud on the call today.
Sarah, maybe
you
there's
know- Go ahead.
maybe there's a tension going on here between what's meaningful to clinicians and what's meaningful to people who want to use the EHR for population health analysis. Having material hardship defined in this way on this slide due to financial hardship is a very rich mine to, or a very rich vein to mine for population health. On the other hand, as Julia and others have pointed out, this level of granularity requires coding decisions that, for one thing, people are not used to now. For another thing, they'll have to be trained to understand, and then they have to figure it out, and then they have to do it presumably accurately so that when this kind of information is aggregated, it will be meaningful for population health research. So I wonder if we're struggling here with layers of understanding for which the EHR is the primary data source.
Lucy,
And I think I'm
that's
very
great.
grateful to that comment, because I often feel that people attempt to put all of their secondary use requirements onto primary users, and that's
Yes.
not appropriate or helpful. It's basically the definition of creating patient burden, right? Or sorry, provider burden in terms of documentation, or user burden. I think though that, the other thing, Sarah, to your point, if not everyone's in the same place, you can do both and create a mapping. But you can point out also that, user preference and user parsimony would maybe potentially yield better quality data with the post-coordinated approach.
Depending on the platforms, right? Because many of our, okay, so what I hear is,
Depending on the user potentially too.
yeah, oh my Lord, yes, because I'm a hierarchical condition queen. So I love coding to specificity, and it boxes me into all kinds of problems, right? So, all right, so I guess with the understanding that we want to build for futures, so what I'll do is I'll come back next time with the unable to obtain blank and the unable to obtain due to, right? And this is not a cacophony of code. This is literally like 1, 2, 3, 4, it's 8 codes. So it'd be 16 suggestions, right? Not a ton, right? And then what we can do when we do, we can maybe present the vote somehow that allows individuals to react to those two different options. But I'm here, 100%. I hear the argument for post-coordinated and pre-coordinated. I feel like I live in this world. It's a conversation I never knew I was going to be having so much. I do want to state also, from a provider burden standpoint, part of what we're doing with our firework is there will be direct, suggestions of concepts possible from some of our implemented screeners, right? So if you use a LOINC form, it could suggest a health concern, which is this thing. It could, hypothetically, right? That's the intent, at least with the technical work. So when you think about the cacophony of code, and you think about the upcoming implementation guide, hopefully there is a little bit of a, an answer there. Does it seem like so coming back with this, the non, with the the capacity for post coordination, which would involve, and maybe then changing the terms a little bit, but coming back with the unable to obtain without the due to and these concepts next time. Does that sound like a good idea?
Sarah, I just have to react to the idea that the firework will solve or settle this. From my point of view, the hierarchy for what EHR designers should pay attention to is start with the gravity project, and then the fire resource needs to accommodate it. Whatever we decide here, hopefully, will have a technical implication that will be embodied in the eventual fire implementation guide.
Oh, yes.
Not the other way around.
I hear you. And I
Okay.
say this, yeah, I hear you. Right. And I didn't mean to phrase it. It's more Sarah trying to honor the half of the work that I do not lead. Right. But I tried to make sure that we influence, right? I don't know if Bob is here to talk about it,
So
but
I'm just reinforcing the work that you lead and how that should be the tail that wags the dog and not the other way around.
that's very sweet.
Thank you.
I do want to call to light some of what Tom is bringing to bear here, that the individuals some of the individuals who've been asking for this pre-coordination are, some of our community-based organization colleagues who try to make the case for what they're doing, right? And do not have tech for at present for post coordination. So I believe we can find solutions that accommodate all needs, and we will bring that back next time. Does it sound like a plan?
This
Hi,
is Bob.
Bob.
How are
Hi.
you?
Good.
So I
Good.
don't think we do not have a problem in accommodating either pre or post coordination of SNOMED terms. The question is, what's the appropriate thing to do, both for representing the information accurately and for making it, shall we say, most flexible and available for the users to go and determine what the conditions are that they're trying to document.
Thank you, Bob.
This won't. Yep, we'll be able to support it either way. The question is, what's the right thing? And that's what I think Sarah's deep in the middle of trying to understand and represent.
Yes, making all stakeholders. Okay, so this is a really helpful conversation. I think this is it's actually a really wonderful example of, what we asked the community to do. We were kind of like, what is the role of the public? And, this is it, guys. Thank you so much for your feedback. We'll take it back. There's a bunch of things comments from John regarding changing secondary to due to, possibly moving to consistency across the causality statement. So if we are going to do post coordination, we should have our financial hardship concept map our other terms so that we're not, we're in alignment there, and then coming back to the community with both proposals next time. All right. Thank you, always.
Hey, Sarah, let me make
Yeah?
one last comment. We just got done doing a test to make sure that fire and the terminology service could support post-coordination of terms as it stands today, given the way we define terminology and value sets, and we were quite successful at it. So this is really not a technology issue anymore. It's now truly a terminology issue. Okay?
Okay. Sounds good. Okay, ready to move on? Sounds like. Okay, let's go next slide. Just wanted to, okay, so this is these goal statements are reflective of what was on the previous slide. So Gravity now has, and again, that might need to change based on our conversation. But Gravity has defined an approach to goals, which is really focused on building kind of, these what we're calling target statements, which are the thing we're aiming for. understanding that really when it comes to the complexities of, terminology, it would be defining every single person's person level goal. We are still working with patient care work group on this, but we know we can make this line in the sand. That at least the thing we're aiming for, the lighthouse at the end of the storm, those are the concepts we feel like we can represent in terminology. So you can see I have made this parent concept of able to afford, which is the inverse of the unable to afford, and just dropped everything in there, all those different concepts. There's one little little comment that I need to note. So adequate clothing. So across gravity terminology, we use the term adequate to define like baseline necessity when there's a really broad spectrum, right? So able to access becomes tricky. So Tom, this is why we're gonna have to talk about that. So there's a wide spectrum of, clothing that one might be able to have access to. So again, adequacy is the term that threads through all of gravity terminology when we're saying we have to meet baseline standards. And these concepts really could be interchanged across domains. So you can imagine these going back into the financial security domain or et cetera. So you also, if we are saying you have parent concepts, which are not tied to causality, you could imagine having able to access blank and not saying able to afford, right? So these statements are specifically about the response to the due to. If we're building both concepts, we might need to build both truths though, Tom. So we have not, so elder care, that keeps on coming up. So will someone submit that? I think we need to get that worked into our hopper. So Tom, does it make sense why it was phrased this way in the beginning? Because if I, like for instance, if I have an individual that can't afford their heat, I, connect them with my care navigator who helps them sign up for utility assistance. The goal of their care plan is to be able to afford heat, right? So that was the approach as it stands right now. If you had able to access, it would then apply to the neighborhood domain of it existing in the community and the able to afford, of course.
That makes sense. I think it's just a little challenging because there can be solutions that don't require being able to pay for it, which is kind of what I feel is implied by afford. I'm thinking of a project that we're working on that would provide Wi-Fi broadband to a senior housing project. So that would be a population health solution to an entire community that none of them have to pay for, but now they have that need met.
Yeah, and it's tricky because those kinds of concerns we had intended to consider in our neighborhood and community domain, right? Because that was when you're solving problems for the many as opposed to solving problems for the one. But this is like where we get, which is entirely, as long as we feel comfortable, and I can't see any problem, like suggesting the solutions that we can use across. The moment you unpack causality and you say not due to, and it's just like everything, right? We are addressing goals and interventions across the person level, ability to afford, and the community level, right? We're doing some of the work that we were considering about doing in the fall. Does that make sense?
Yeah, it's the afford thing also sticking with me. And again, I can't get the chat to work for some reason, so sorry about that. But I still think it should be obtain or access, because you don't have to, pay for something directly to be able to have it. And what you want is to have it, not to pay for it. There's no reward for paying for it. The reward is having access to the thing. So I get your point about how you're trying to speak to, I don't have this because I can't pay for it. But I think a fair number of patients would say, I just want to have it, not that I want to afford it.
Well, yeah, and again, I think just as you were saying before, both are true, right? So again, I think the hazard of this slide, it was made to respond, it was to respond with the findings and diagnoses or concepts as expressed on the previous slide. So again, if we're keeping our terms, it wouldn't be access, it would be obtain, right? Because access is something that we have chosen to not say for all kinds of reasons.
Yes, that's right.
But we can, if it doesn't, if again, so what I'll do is I'll come back with both again next time, because we have to respect the efforts that led us here. And I can't see a problem in us collectively deciding whether these are necessary once we approach with a general statement of able to obtain. Sound good?
Sounds great. I think over specifying is a little bit the perfect being the enemy of the good.
Yeah. And if you only knew how simple this was compared to the goal statements that people were trying to represent, I'm sure you can imagine, right? But yes, so we will come back with able to obtain. And again, and this is again just in response to the slide we had before. So we're coming back with unpacked versions of both the diagnosis statements and the goal statements next time we meet. Sound good? And the great thing is a lot of our work for the fall will be done for us. So, okay. Sound good, folks? Okay. Next slide, please. All right. I just wanted to briefly cover what we're approaching with the interventions again. So the approach is as follows. So there'll be broad programs from previous domains, all the ones that roll over, like Community Action Agency, Area Agency on Aging, etc. There'll be specific programs that are in common with previous domains, such as child care assistance programs. And then there also are some, when we analyze, the diagnoses or concepts we have for material hardship, we are missing some. So we'll also add specific concepts such as utility assistance programs, which my argument is that then they should be applicable to financial insecurity too. So when we look forward into material hardship interventions, again, the bulk of all the concepts that roll over for all of our socioeconomic domains will be dropped in. There are specific programs that we'll keep, and then new programs we'll be adding, and they'll all be inserted into our the intervention approach that grounds the Gravity Project work.
Sarah, this may be out of scope. Please tell me if it is out of scope. I'm suddenly wondering, with respect to interventions, which are actually referrals, who does this? Is this telling the patient, call 211 and find one of these? Or are we expecting the site of clinical care to establish these connections? Is this out of scope? Because I'm suddenly, forgive me, everyone on the call, for not having understood this my entire professional life, but I now realize that many providers provide a list of 2 or 3 choices along with the instruction, call 211 and get something.
So I think, so the truth is, Lucy, if we've done our best with our intervention framework to, and again, try not to create a cacophony of things, to build concepts that are interchangeable across different practice settings and across both clinical and community settings, right? So interventions are actually not all referrals, because sometimes things are happening in the clinic. Sometimes clinics have on-site food prescription services, or sometimes they have on-site social work. And sometimes they have on-site community health teams or care navigation or anything, right? Sometimes folks are signing up for SNAP, and and doing signing up through HMIS in clinical settings, right? So the labor, where the labor happens is diverse. Like for instance, my food bank in Vermont has a social worker embedded in the food bank who helps individuals sign up for SNAP, right? So I can refer to the social worker and everything's taken care of. It's very lucky. So if you look across, the core of our intervention approach are the programs and professions that need to be, that we agree on, which is where you can see that these are just organizations and programs. We then insert them into the syntax of our intervention structure, that it is then able to be utilized across all of these different kinds of places, whether it be the Community Action Agency or the FQHC that has embedded social work, or the Independent Pediatric Office in rural Vermont that has nothing, right? So depending on what one has and what one's community offers, you're able to use the terms that are appropriate for you.
Okay.
And so, we should also be aiming for what's in the future, right? So now increasing numbers of states and healthcare systems are purchasing these referral platforms where you can go in and link a specific patient to a specific kind of service based on their attributes and needs.
Like Aunt Bertha.
Yeah. So the
Yeah.
expectation is that increasingly, like right now, you give people a list because the only alternative is to call 500 places and hope someone answers the phone and says, yeah, they'll see your patient. You don't have time for that. But if you were able to say, give the patient the next appointment at their appropriate place, then you could do those with a click.
And we do try to build for those futures. Oh, Greg's speaking. Greg, this is you, man.
Yeah, suffice it to say that there are many cases in which that kind of thing sounds great and would maybe even be great, although I think it's actually a subset of the range of possible resources and interventions. And so we do, I think on another call, someone pleaded that that kind of automated integration be considered an optional value add rather than the kind of thing that we are trying to standardize and enforce across the board in what is really a vastly diverse service landscape.
Yeah, Greg, this is Mike. I agree completely, but on the ground, I think this kind of work can also influence a vendor community that instead of just building out more sophisticated versions of here's your list of things to call, they can work at the mechanics of making better connecting possible on the community level. And that does need to be supported with some type of coding standards so that you can do closed loop referrals for both individual care purposes and population health purposes. So there's a compromise point in here somewhere, without getting too far into the weeds about how deep to dig into interventions, that we probably need to get to as we do this work.
And Mike, I do believe when we review these concepts, well, I do believe we try to do that, right? So we do have the referral to community referral platform, like easy button, like go, right? And then from, we do build for the perspectives of folks that work in systems like my own, which have none of those things, right? So, and again, the intent, and again, when we developed our interventions framework, we literally tossed it in front of stakeholders all over the ecosystem. Like, if we say it this way, will it work for you there, you there, you there, and you there? Yes, great, right? Because then all we needed to do was develop the term, and then the community could figure out, or the person, or the organization, or the system, right, could just use it, just like we use language, right? So that's the.
And without this work, none of these future platforms are going to easily be able to interoperate. I mean, that's the reality here. So that's why this is important. Yeah.
So the hope, again, but that's a hypothesis from the terminology side that needs to be borne out in our pilots. And again, really, really thankful for our early adopters and innovators. Again, a little shout out to DC Crisp, who always writes with, we're doing this and we encountered this complexity. And I'm like, okay. So this is part of what we hope to see in our kind of tiered pilot approach, is some individuals will really just be piloting terminology. some individual will be piloting standards, right? So, and then all of that will come back and ensure that what we're doing is informed by on the ground individuals so we can do a better job.
Sarah, this is Denise.
Yeah.
Hi.
Hello.
Back from COVID duty here in California. Just wanted to say, so we don't stop, that I think it is very important that we build something in to close the loop. I was on the committee to build our all-payer database here in California, and a lot of things that we're discussing were just pushed, not just, but were pushed off as part of the value added. We're going to sell that later as value added. As a registered dietitian, I'm not allowed to do anything except stick to my area. And referrals are really heavy, but I've had JACO on my tail and other, I'll call them watchdogs, coming in, looking at my notes saying, did you refer? Yes, I referred. So whether or not the social worker was able to get the client to go ahead and do what they needed to do, either with the number or referral, it was still up to the rest of the team, which put a burden on us to really say what needed to be done. So I'm just advocating for let's do what we need to do to make sure that these referrals are built into the system with coding or otherwise.
Here, here. All right. Okay, so lovely. We have 4 minutes. We might need to extend our meetings or have meetings more often because there's a lot to say. So if it's okay, I'm going to quickly push through some concepts just because what we're doing right now with stress is just identifying stress concepts, but I want to keep on going just to get things in front of all of your minds. Next slide, please. We can pop through some of this very quickly. Next slide. Next slide. You will remember the origin of our stress definitions, and you will now see how it was on the NASEM report as a critical first must-have concept, which is partly why it's on our plan. We got some questions about why this was on here, so that's why. Next slide, please. Again, you remember this slide from before. This is just to orient to stress literature. Again, we're working with colleagues at the Stress Measurement Network regarding our subject matter experts, but their stress exposures and stress responses. We had a really robust conversation about this last time. Next slide, please. I really wanted to encourage individuals to explore the collation of tools that the Stress Measurement Network already has done for us. So sometimes there's an organization out there that has its finger on the pulse of the domain and gathers every single thing into an organized web page. And that is the Stress Measurement Network. So as we work going forward, collating our screening tools, the Stress Measurement Network has them all organized by daily stressors, by burnout, by caregiver stress, by work stressors, by stigma and discrimination, by pregnancy, trauma, relationship conflict, and major life events, right? Existing screening methodology for all of these things. So for those individuals who kind of want to do a deep dive into the literature, and these are all referenced and cited screening tools, the link for the Stress Measurement Network is, and I will put it in the chat as well, because it looks like, of course, that link is not live and my colleagues might not be able to get to it.
Sarah, there's something missing here.
What?
The kitchen sink.
Oh, yes. Oh, and Lucy, I made you a word cloud. This is like my gift to you. I try to make my Lucy word clouds.
Lovely. That's why I reacted. Thanks.
I'm sure. So homework for next time for folks who want to submit is to look and see what our subject matter experts have already done for us. Again, you'll recognize some of the founding members of the Stress Measurement Network as the amazing Nancy Adler, who was also one of the key authors on the NASEM Report 1 and 2. Look, you can all go there and research if you desire. We'll also be pulling our subject matter experts' wisdom into our data set, so no need to do that too quickly. Next slide, please. I think, and just reminding folks about general stress tools, because right now, most of the screening methodology we have in kind of the multi-domain tools regarding stress just ask for general stressors, right? So not about specific stress, not focused, for instance, on discrimination or bias or pregnancy-related stressors, but just general, are you stressed? Again, regarding discrimination and bias stressors, I'm going to state again that we've already engendered to discuss racism and its effects on health in the fall. And, you know, I think we're already agreeing with the subject matter experts that when it comes to measures of minority stress, knowing that we can do this work in time, that specifically, that might be best to address during that work to ensure we have the subject matter on hand to do so. We are luckily working with experts from across the LGBTQIA community on some of our intimate partner violence work. And I say that because the minority stress concepts and paper we saw earlier was referencing some of their work. Oh, Asha, thank you. All right. Next slide. Again, so far, again, these are more general stress tools. You can see the prepare stress question. You can see the general Finnish Institute of Occupational Health Occupational Stress Questionnaire, and again, the perceived stress scale. Next slide. I tried to make this a little tidier and smaller than last time for folks who could not see the, you know, the eye chart from last time. So this is all pulled directly from the compendium. The reason why I placed this here is, again, oh, thank you, Carrie. So again, we are likely not going to have to suggest diagnostic concepts for stress because the compendium, well, the literature of what's already out there from a SNOMED and ICD-10 perspective is already so robust. So I'm anticipating anyone having to kind of make a case that any new terminology is required here. So the heft of our work will be in building a critical screening questions and answers into LOINC so that we can use them as part of our work. All right, we did it at 5:32. Sorry to spend so little time on stress, but we are wrapping up material hardship, and it really is important to nail that down. We are hoping to not save all of our voting up for the end. So I know what I need to do with material hardship to bring it back to the community next time based on our conversation. We do hope to vote on material hardship in not too long. So really hoping to get that correct and then settle material hardship and move forward into our other domains over the course of the next few months. Tom is asking, are we distinguishing between psychological stress and physical stressors? So if you mean, we're not actually distinguishing on anything right now. So if you look at the initial slide for stress, it talks about, you know, like the trigger and the response. So the net is quite wide right now regarding what we're including in the set, but it will be winnowed over time. So if you have suggestions for things that you feel like need to be included, just submit them and we will review it. Whew. All right, next slide, I think is the community homework slide. Next slide. Oh, these are, sorry, this is actually a little bit, oh yeah, so material hardship screening, diagnosis, goals, and interventions. We just forgot to change the title there. And submitting stress screening and diagnoses comments. Thank you all for your time. What a lovely conversation as usual. Any other final comments before we sign off?
Thanks, Sarah. The amount of ground you cover in an hour and a half is stunning.
we collectively covered. And Tom, I hope I answered your questions. Yeah, I hope, thank you, Lucy. I hope I answered your question sufficiently, Tom. Again, I would never want to limit us until we have something to respond to. So if you have an idea of something you feel like needs to be included, give it, and then we'll go from there. Thank you, friends.
Thank you, everyone.
Thanks.